Hello and welcome to the Feeling Good podcast. I am your host, Fabrice, and joining me here in the Murrieta studios is Dr. David Burns. Hi, David.
Hi, Fabrice.
Dr. David Burns has been a pioneer in the development of cognitive therapy, and he is the creator of the new team therapy. He is the author of Feeling Good, which has sold over 5 million copies in the United States and has been translated into over 20 languages. He is an emeritus adjunct clinical professor of psychiatry at the Stanford University School of Medicine. This is episode 49 of the Feeling Good podcast, and we have a treat for you today. I have David here with me, of course, but I also have Dr. Matthew May. Hi, Matt.
Hi, it's a pleasure to be here, Fabrice.
And we are doing, after people having really praised our live session with Mark, we're doing a live session today with Marilyn. And you're in for another treat, really. So I just wanted to briefly introduce what we're going to do today. The session is with one of David and Matt's student, Marilyn, who has been diagnosed with lung cancer. And so she came and did some work on that. The segment we'll listen to today will be the testing and empathy part of the session. And we're going to talk a little bit about what happens in there. But before that, I wanted to kind of introduce Matt. All right, just for our listeners, I just want to mention that we are recording this at a different time than the other part of the interview and for the session. So the audience may hear a slightly different sound quality. But anyhow, Matt, thank you so much for participating in this live session. And, everyone knows David and they know a little bit about me, but they haven't met you yet. So if you could perhaps tell us, what you do, how did you come to know Team?
Thank you, Fabrice. It's quite a pleasure to be here. And thanks for coming into my office to interview me and talk a little bit about Team. I first met David when he came onto the inpatient psychiatric ward at Stanford, where I was a resident. And
so you trained in psychiatry like he did, yeah?
I did, and he came there just to volunteer. He's been volunteering his time on the adjunct clinical faculty there for several decades, and he came to teach residents how to empathize with folks who were suffering from depression, anxiety, and relationship problems primarily. And what I saw there was pretty fascinating to me. He had a more systematic and I think effective way of empathizing and listening to patients than I had encountered prior to that. And in fact, if anything, I felt like I was witnessing something akin to Michael Jordan in basketball, something far ahead of the game that was being played up to that time. So I decided that I would start working with David, and he allowed me to train with him, even though I was just a medical student, and his normal training seminars were for residents. And then one memory I have from that time was that, we would try to set our egos aside and practice with very difficult patient scenarios where maybe they would be scared themselves, angry themselves, and criticizing us. And then we would do our best to understand and listen and get immediate feedback. And this type of training was just phenomenal because we could see right there the errors that we were making and then work hard to improve and do a better job of connecting and listening to patients who were really suffering. But the kind of game changer for me was one day I was on an OB-GYN clerkship. And I'd been up all night helping deliver young babies into the world. And I was pretty exhausted and I was kind of in a protective mode of children. And walking out of the hospital, I noticed that there was an older gentleman and holding hands with a young man and taking him into the hospital, carrying a large manila envelope. And the boy was pretty frightened. You could tell. Mm. And the man was getting frustrated with him, and took the manila envelope and swatted the boy right in the face with it, in a way that was, I think, more shaming than actually painful.
Yeah.
But I had no idea what to say or what to do. I just kind of froze up, and then on the drive back, I felt tremendous guilt and shame that I'd failed that young man. And I discovered David in the training room, as usual. And he was alone in it. That was a little bit odd. But he explained that the residents were off taking the Pride exam, and that we didn't have to meet. But if I did want to meet, it would be a great opportunity for us to talk about, or perhaps for me to experience the model if there was anything bothering me. So
that was your first experience, firsthand of the model?
That's right. And within about 2 hours, my guilt was completely gone. I felt completely better. And I had seen how we cling to our guilt and to our negative thinking.
Right.
And how to let go of that. And that was quite miraculous for me. And I decided right there, if I could spend my life doing that and helping people in that way, I'd be pretty much tickled and happy, and feel a lot of meaning and joy in my life.
Mm. And so, you became a psychiatrist, and then you went into your own practice, right?
That's right. Yeah.
Now, you practice very differently from other psychiatrists, or from the majority of psychiatrists. How would you characterize that?
I think that's true, Fabrice. I spend very little time prescribing medication, and most of the time that I spend with my clients or patients, whatever you'd like to call them, is spent trying to empathize, identify the problems in their lives, and understand them at a cognitive level and a behavioral level. And so I'm mostly doing therapy to help people with anxiety, depression, relationship problems, unwanted habits, and addictions.
Yeah, so it's somewhat unusual. Most of the psychiatrists that I deal with, I refer them out to give my clients some medications. So this is really different from the majority of psychiatrists. And what did I want to say? David teaches his Tuesday group for clinicians, and he also has a Wednesday group for residents. But you also teach.
That's right. That's one of the things I like to do more than almost anything. I teach an online group for therapists, and I teach residents at Stanford and other trainees at Stanford.
Yeah, and I may add to this that you also have taught me, and you have taught a group of people who met with you, kind of like the same way David does that. And I have to say that I'm still doing some training with you, more like a consultation group, and we do this as we go hiking.
Yeah, that's been a tremendous pleasure to do that. Just yesterday, we were up at the Dish hiking.
Yeah,
and I always notice that it never feels like we've walked anywhere because we're so mentally engaged.
That's right. The body does the job, and then we get busy doing other things.
That's right. It's been really fun doing that with you, Fabrice.
Yeah, I want to mention that because you really give a lot of your time and talent. So that the rest of us can practice the Team CBT model, which, as people have seen now after listening to the podcast for almost 50 episodes now, has really, for me, has changed the way revolutionized the way I do my practice. So
I'm so glad to hear that. I think it's one thing to help one person, but if I can help a therapist improve their game and pass that on to many others, I feel like I'm part of a spreading ripple, that there's a kind of domino effect, and I'm hoping that that's making the world a better place, that just as one person improves and feels better,
Yeah.
that their family members feel that
Yeah.
and feel that relief, that can spread outward. And so I'm so delighted to have anyone training with me and learning these methods.
And just to add to this, for people who are interested, you have a practice in Menlo Park, and people can probably Google you, Matthew May, MD, on the internet. And I also want to say, knowing you, that you have quite of a different style than David. And people are about to discover this as you and David co-facilitate this session with Marilyn. So thank you so much. I'm so glad to have you as part of this podcast.
It's a pleasure, Fabrice. Thank you.
All right, so let's listen to the session.
And so, Matt and David, if you could maybe talk a little bit about what happens in this segment. You start with Marilyn's brief mood survey, right? And the scores on this brief mood survey were fairly high.
Absolutely, yeah. And in a strange way, I always feel somewhat reassured when I see high mood scores, because that means that the negative thoughts are quite active, will be easy to access.
Yeah.
And there's real work to be done. If someone comes in and they don't have elevated mood scores, I feel kind of concerned that maybe it would be time wasted for them. But I felt this is just wonderful that Marilyn is, paradoxically, it's wonderful that she's feeling this way today, so that we can really offer her some meaningful help.
I know, it is a sort of paradox. One thing that I noticed, and you may comment on this, David, when you did the live session with Mark, his scores on the mood survey were not super elevated, and yet he did tremendous work. And so I'm wondering if that's because the feelings were not really active when he started, or can you talk about this?
Well, yeah, right. There's a lot of different ways to be depressed and upset. In Mark's case, he's a pretty chipper, happy, high-functioning, and very warm individual. But when he thinks about his oldest son, who's not living with him, he has his family that he's living with now, but his oldest son from a previous marriage, he's never been able to get close to him. And when he thinks about that, he feels like a failure as a father. So it's kind of like this one thing is bothering him in an otherwise pretty fulfilled and productive and joyful life, and so he's got to kind of zero in on the thing that's bugging him to get really, really upset. Other people are more in the zone that Marilyn is in today, where they're depressed, and they've been depressed pretty much all day, every day for weeks or months, and
it's
many
more pervasive.
Pervasive, and some people for years or many decades. Then they haven't even had one happy minute.
And sorry, you were going to say something?
I had another quick point about the brief mood survey. Another thing, when you hear the scores, when we start that part of the session, just see how just extremely severe the scores are that Marilyn has been experiencing. They're really as severe or more severe than many people that are hospitalized for depression. And even some receiving electroconvulsive therapy. And one of the take-home messages is that you've got to be using these assessment tools to find out how your patients are really feeling. And then another take-home message of it is that we're making ourselves accountable for the first time in the history of psychiatry and psychotherapy and psychology, that we're trying to bring about change in today's session. And when I was a psychiatric resident, there was never any idea about that people came and talked for weeks and months, and we never expected anything much to happen. We're going to try to bring about change in today's session. And so we're going to measure how is Marilyn feeling right now at the start of the session. And then at the end of the session, we'll measure it again. How is she feeling right now? So we'll get a before and after, so we can see to what extent was the session effective or or ineffective.
Yeah.
And if therapists have the courage to do this, you can transform your clinical practice. But if you don't use this type of assessment device, I think the potential for growth and improvement as a therapist is very limited.
It's so valuable to have that immediate feedback on how did that interaction with the patient affect them in reality, not how we just imagined that it affected them.
Yeah, because the way we imagined it won't be accurate.
Right.
And also, if you get the feedback right away when the session is fresh in mind, then you can use that for growth and learning. And if you fell short, then you can try to improve next time. And if you hit a home run, you'll know to do more of that kind of thing the next time. So your patients become your greatest teachers.
Mm-hmm. These scales have also taught me just about the nature of our feelings. There's something kind of confusing that there's a list of negative feelings as well as a list of positive feelings. And sometimes we would imagine that those would be on the same scale, but they're actually completely different scales.
Right. Yeah.
That someone can feel simultaneously very, very joyful and very sad.
Yeah.
For example.
Yeah. Happiness is not the opposite of depression. It's a different dimension, and that's why we measure both of them on the same scale. You can't assume that because someone's depression score is vastly improved, they're only a little bit depressed, and they're going to be happy, because often the happiness score doesn't begin to go up until the depression is down near zero, actually.
Yeah, so we could have things like a person would feel really joyful that their child was born, but simultaneously real freaked out and anxious at all the work they'd have to do.
Yeah, that's a good point.
And of course, as we start this segment, Marilyn has already brought her mood survey as well as the daily mood log, which also, when you look at the daily mood log, the emotions were all at 100%. And the belief and the thoughts were also at 100%, so very elevated as well. And so you actually went into empathy on both of those things, and also asked Marilyn some questions about her situation, what was her state of mind, and what was going on for her. One thing I noticed, I found that interesting, because this is the first time I see you both, David and Matt, in the same room working together at the same time. So I noticed the difference in style. There was like a contrast where, David is really, focusing on thought and feeling empathy. And I mean, you're all, using the 5 secrets very, expertly. And Matt, it felt like you were more focusing on the I feel statements and the stroking. That was my impression. Maybe you may disagree with me. What would you say?
I noticed that too. It was a good tag team combination, I thought. And I feel very close to Marilyn, so it's very easy for me to admire her, to use the affirmation or stroking method. And also I just was legitimately feeling the feelings that I was having, and I had to get them out and had to talk about some of the experiences I was having emotionally, and hearing about a dear colleague of mine being diagnosed with cancer.
Yeah. And of course, as people listen to this segment, since we're focusing on getting the information and having Marilyn talk about her pain and her problems, people may think by the time this podcast ends that, wow, this is really hopeless almost, because we're focusing on the negative. So do you have any words of wisdom for our listeners about what's going to come next?
Really, just a quick one is, I think during the empathy phase, and I agree that what Matt did was just really beautiful, the compassion and the warmth, as well as summarizing the patient's negative thoughts and feelings. And I think in the empathy phase, you want to go with the patient to the gates of hell. And errors that therapists typically make in empathy phase of the session is to try to cheer the patient up, or reassure the patient, or help the patient in some way. And that usually comes across as very irritating and annoying to patients. And empathy is really very simple, although most therapists don't do a good job of it. but it's really just reflecting back what the patient is telling you, what the thoughts are, what the feelings are, and to show some acceptance of that, and to give the patient a place to cry, to feel those feelings without trying to do anything to change anything. Later in the session, we bring in some powerful tools for change. But it's not a good idea, I don't think, to do that during the empathy phase. Now, with my having said that, I think the therapists who are listening who want to learn how to do this would probably need to get some training to learn how to do it, because you hear these words, and then I see therapists still making those mistakes of trying to jump in and reassure. And also what Matt did was not like trying to reassure or cheer up Marilyn. That's a subtle point, but yes. It was just speaking from the heart of feeling sadness and compassion and admiration.
Yeah, it's about connecting, right?
Yeah.
I agree with you, David. It's so true that, and it was true for me too, that when I was trying to learn therapy, that my instinct was to try to help, fix, cheer up, and that always backfired. It came across as sort of demanding or critical or a put down.
Yeah,
and
or patronizing.
Yeah, it took practice to let go of those habits. But I also think it reflects well on those individuals that their intention is really good. They really want the best outcome, but they're going about it in a way that's not effective.
Yeah.
And one thing I noticed that you brought the empathy part to a close by asking Marilyn, do you feel like we're getting you, that you've been heard?
Yeah. And we could have actually said, are we getting an A, a B, a C?
Yeah.
I often do that. It's a little embarrassing to do that, but patients will be honest with you. But it seemed like we were all there together, so I didn't go that extra step.
Yeah.
But before you go on to the next phase of the session, which is agenda setting, you've got to have a warm connection where the patient feels cared about, liked, admired, accepted, and really feels that you've heard what they have to say. And sometimes patients will say, I'm not ready to go on yet, I need more time to talk and be listened to, and that's fine too.
Yeah. Would you like to add something, Marilyn?
I just really experienced an incredible amount of empathy from both Matt and David, and that really, number one, settled me into the session, and also provided me with hope that, I'm being understood, I'm being seen, and this is really going to be helpful today. All
right. Well, without further ado, let's go on and listen.
One other quick thing is the expectation of the therapist. There's something we don't talk about, but I've heard patients go to therapists, and then that first session therapist will say, this is going to take many months, we'll be working together, and then it becomes a self-fulfilling prophecy. Yeah. And I think we all had the expectation today that something magical was going to happen today. Mm-hmm. And while on the one hand this puts us under pressure, and we're doing measurements to find out if something magical really can happen, and many listeners say, how can you do work magic with someone who's dying of cancer? They're inevitably going to be feeling awful, and it's the event itself that's inherently awful. But if you have that expectation, of course you have to have the tools to back it up. But when I work with people now, I pretty much expect that something fantastic is going to happen today, and we're going to measure it and see if that, and that can be a different kind of self-fulfilling prophecy. But in my teachings, I have a psychiatric residence at Stanford, and I know, Matt, you've experienced the same thing. When you tell them that we can often make depression disappear in a single therapy session, or just a couple of therapy sessions, they get angry, and they think you're a con artist, because they've been trained that depression builds up over years like some huge mountain, and that you have to just shovel it, shovelful by shovelful for many years before you could begin to expect change. But we recently had this Mark Noble, a neuroscientist, visit our Tuesday group. I think he had learned about team therapy from these podcasts, I suspect. And he's been doing research quite relevant to psychiatry. He wanted to come and share it with us. But he said there are all kinds of neural precedents for rapid change in the brain. Like he says, if you touch something that's hot and you pull your hand away, the pain suddenly diminishes. And similarly, he says that these distorted thoughts is like pain, physical pain, or touching something hot, and that when you are able to turn off those distorted negative thoughts that are the cause of the depression and the anxiety, of course the symptoms would rapidly or almost immediately diminish. Now we'll see if that's possible in this session with someone with a horrible, real, disastrous problem that isn't just a distortion. The cancer is real, but would it be true that even in this situation that there's some kind of distorted thoughts that are creating the pain rather than the actual external event?
All right. So thank you for adding this. Are we ready to start listening to the testing and empathy segment? Okay.
Yeah.
Why don't we start out? I think we're saddened but touched and honored and grateful to see you here today, Marilyn. It's been a little while since we've hung out together, and how great to be working with you today, Matt. A very, very special experience. But why don't you tell us who you are? The listeners know who I am. They know who Matt is, and tell us who Marilyn is, and then we'll dive into the topic at hand.
My name is Marilyn Coffey. I'm a licensed clinical psychologist with a prior practice in Oakland, California. And I met David several years ago at one of the intensives. And I've done other workshops as well on anxiety and post-traumatic stress. And at first I was a member of Dr. Matt May's consultation group, which was mind-boggling and very educationally expansive. And then I eventually switched over to David's Tuesday group and had been attending that regularly until about a year ago, when things in my life kind of changed because I had a fell and was not able to drive. But I'm very, very grateful to be here today and honored to have the opportunity of working with both David and Matt. It's a real gift for me, and so thank you both.
Why don't we just start out with looking at the testing, then we'll kind of look at your daily mood log, and then you can kind of tell us what's been going on. But I noticed on the brief mood survey, how depressed are you feeling right now at the beginning of the session, and then we'll assess these things again at the end of the session. But the depression is 17 out of 20, which is real severe depression in the direction of extreme. You're extremely sad and down and feeling extremely hopeless and discouraged, and a lot of loss of a lot of worthlessness and inferiority and loss of self-esteem, and a lot of loss of motivation to do things, and a great loss of pleasure and satisfaction in life. And the suicidal urges is 0. The anxiety is 20 out of 20, indicating the most intense anxiety a human being is capable of experiencing. And the anger is 18 out of 20. And just as an aside, in terms of perhaps making a persuasive point for therapists to use either the brief mood survey or other kind of assessment instruments in therapy, our perceptions of how people feel inside are the research that I've done, therapist perceptions are pretty much less than 10% accurate. And what that means from a practical point of view is you won't know how your patient is feeling. You think you do, but you don't. And if we met you today, and we just had some pastry upstairs, we've been laughing and joking and having a happy time of it, you would have no idea that your feelings inside were this incredibly severe and overwhelming. And then on the positive feelings, which goes from 0 to 40, is an 8, indicating almost no positive feelings whatsoever, just a little bit of somewhat I'm feeling good about myself. I feel somewhat close to people, somewhat motivated to do things not at all worthwhile, not at all calm or relaxed. And ideally, these things would be in the a lot and extremely type of range. And why don't you tell us what's been going on? I know you got some shocking news, a month or two ago, and we have your daily mood log we can go over here in just a minute or two as well.
Well, last March, I had a cough, and I was coughing up green gunk, and I noticed sometimes I was experiencing some shortness of breath, which I had never experienced before in my life, even when I was sitting down watching TV. So it became a concern, and so I made an appointment with my doctor, who assumed that I had bronchitis again, and so sent me for a chest x-ray so that she could prescribe antibiotics if indeed I did have bronchitis. And because I was feeling so good, I never really felt sick, I kind of put off the chest x-ray for a week or two and was on Telegraph Avenue in Oakland and passed by the x-ray place and said, you know what, the Sam Hill, go get the chest x-ray. So I went and got the chest x-ray, and the technician said to me, well, the doctor here wants to see you, which really surprised me. I'd never had that before. And when I went to see the doctor, he had my chest x-rays on a screen and says, you have lung cancer, and I can't even see your left lung because it's full of fluid. And I was in complete disbelief. I've never smoked in my life. And I was still feeling good. I mean, I had this cough, I had a little bit of shortness of breath, sometimes more severe if I was taking my dog for a walk. So I called my primary care physician, went to see her, and she said, you need to go to Alta Bates Hospital ER right away. So I went into the ER, and a friend of mine joined me, and the ER doctor confirmed that I had lung cancer and sent me upstairs to have the drainage in my left lung taken care of. So they put a needle in my back, which was painful.
Was it horrible?
It was painful. It was horrible. Yeah. But once the needle was in, it was uncomfortable but bearable. I mean, I remember holding the nurse. The nurse was there, and I was probably shaking her hand like Donald Trump does. And when I looked up, I saw 2 large containers of blood that they had taken from my lungs. And he again confirmed that I had probably stage cancer. And then I had a chest x-ray. At some point, I get confused, but at some point I was diagnosed with stage 4 non-smoker's lung disease that was incurable, and was referred to an oncologist in Berkeley, who again confirmed that diagnosis. And eventually he put me on a medication called Tarceva. And when I was first told I was going to be given Tarceva, I called the insurance company and was told that my copay was going to be $3,000, which I obviously could not pay. And I got hysterical on the phone talking to the insurance person. So she eventually talked to the social worker at the cancer place. And again, when I walked into the cancer place at Alta Bates, at Herrick, I was in complete disbelief because people there looked really, really sick. And I had never felt sick. So it was really scary for me and terrifying. So the insurance people talked to the social worker, and so eventually I was able to get the Tarceva, which I've been taking now for about a month. I did go to Stanford for a second opinion and felt much more treated competently by 2 oncology physicians and an oncology nurse who spent like 3 hours with me, all of whom listened to my lungs and confirmed that they also would have prescribed Tarceva, and said that if the Tarceva doesn't work, that they would have other options of treatment for me. So I left there feeling a bit more hopeful, but still really scared because I still can't believe I have cancer because I feel so well. And there's a history of of cancer. My mother lived till she was 90. She died of lung cancer that had metastasized to her brain. My father died at 68 of a massive heart attack. My father's sisters both lived well into their 80s. And my mother's one brother lived into his 80s. The other brother died very young of prostate cancer. But, I mean, I was expecting to live a long life. I wasn't expecting to be diagnosed at this age with an incurable disease. And it's been really hard.
Marilyn, my heart is breaking as you're describing this such a disturbing experience on so many different levels, terrifying, really hard to believe. Just you expressed that sense of it's just horrifying to be well one day, to not be in any distress, and you've never felt sick, and then to be handed a diagnosis that was, I understand, likely to rob you of your life through no fault of your own. You never smoked, and then to go through these disturbing and kind of painful procedures, draining blood out of your chest, and we'd emailed back and forth, and when I woke up this morning and I thought of you, tears came to my eyes because I have so much respect and admiration for you. You've got to be one of the kindest, most patient, thoughtful, gentle people I have ever met. And in all the teaching groups for years, you would come and you would always be front and center, right on my right side. It's nice to reverse that role a little bit today. I'm at your right side today, so it's really a pleasure for me to be with you. And to talk about this with you. Thank you.
Thank you. Forgot to mention that also during this time I did have lung surgery because my left lung had filled up again with fluid. So I was at Merritt Hospital in Oakland with a lung specialist, and they drained the fluid again from my lung, and then he stretched out my left lung. So I was in intensive care for 2 days and then moved upstairs. And had these tubes in my left side for a couple of days, and then came home. And one of the nice things I liked about being at Merritt Hospital is I could have my dog there. So
oh, really?
Yeah.
Wow.
People, because there's a private room, and many patients on that particular unit, it was a cardiac care unit as well as a lung care unit, had their dogs with them. So my friend Danielle brought Maggie. So it was nice having Maggie there, and kind of surprising to see various people show up that I didn't expect. So, but, I guess having the surgery kind of reinforced the fact that it's true, you have lung cancer, and,
It's really, really important to have that support.
Yeah, it was very important.
One thing that you said was that it was frustrating that the cost of the treatment was something that you couldn't afford, and that's upsetting to me as well. When you learned about that, you said you became hysterical on the phone, that you wouldn't have access to a potentially life-saving or prolonging treatment. And I wonder, what was that like for you?
It was terrifying, and I remember telling the woman from the insurance company, sobbing that my life is on the line here. I mean, I need this medication. This is the only hope that's been given to me so far by an oncology doctor. And, if I have to put it on my credit card, I will, but, I can't afford to go into debt because I live on a very fixed income since I'm retired. And so somehow it was worked out with the doctor, the oncology doctor in Berkeley, had free samples. So I was able to get the Tarceva from the social worker at the oncology office, and then I got the Tarceva in the mail, and will continue to do so. And because now my disease is considered catastrophic, I love the language they use. Doesn't provide much hope for me, at least in my mind. So I am getting the medication. I've been taking it, and when I saw my primary care physician this week, she said that my left lung sounded much better. and because I broke out in a rash on my face
from the medication.
The oncology doctor and the doctors at Stanford said was a hopeful sign that the medication is probably working. So I'll know more. I get a PET scan on the 19th, and I see the oncology in Berkeley on the 22nd, and hopefully they'll know whether or not the medication is in fact working. Then I'm back in Stanford the week following the 22nd appointment. And the other thing I need to add through all of this is this has thrown me into a huge dark night of the soul crisis, because I'm really terrified of dying, and I'm really doubting whether or not there's a God or is there an afterlife. And, I'm wondering if I feel duped by religion. And I have more spirituality books in my house than I do psychotherapy books, which is interesting. And when I look at all the books written, at least in my living room, by these spiritual authors, I wonder, are these people all delusional? So it's been a roller coaster ride. It really has been. And
your intelligence is a bit of a curse in that regard, right?
Yes.
Critical thinking. I feel so sad and shocked as well. I can imagine when you were in a panic, you were feeling some rage at the same time.
Yes.
And I don't mean to turn this into something political, but I feel like there's an inherent conflict of interest between healthcare and free enterprise. Mm-hmm. And I felt for a long time that we need a national health insurance, and I know it's such a political thing right now, but I just it enrages me that we have the kind of system we have. I'm going to be right back. My tissue thing is right around the corner here. Oh, you've got some? Okay.
Plant ahead.
You gave us a daily mood log here that we can go over, recording your negative thoughts and feelings, Marilyn. And the upsetting event at the top is just being diagnosed with incurable stage 4 non-smoker lung cancer. And then you recorded your feelings. In this first couple ones here, which were you didn't...
they all so sad, blue, depressed, down, and happy.
Okay, so that whole category of depression is 100% plus. All the anxiety feelings are 100% plus. Guilty, remorseful, bad, ashamed. And what's this word here?
Because of my alcoholism.
100. And then feeling inferior and defective, 100. And then lonely, alone, and abandoned, 100. And hopeless, discouraged, pessimistic, and despairing, 100. Frustrated, stuck, thwarted, and defeated, 100. Angry, mad, resentful, annoyed, irritated, upset, furious, 100. And was there a second page in addition to this, the back here? Because I thought I had seen
there it is.
One. Yeah. There we go. And then your negative thoughts, and you believed all of these 100. This cannot be true. I've never smoked. Number 2, I'm going to die sooner than later. Number 3, I'm terrified of dying. And that's again 100%. And then is there a God? And that's a kind of a question, and we could convert that to a statement. There might
not be a God, or I doubt there is a God.
Yeah. And is there life after death? There is no life after death, 100. And I cannot believe I have cancer, 100. I've wasted a lot of time in my life because of my alcoholism. I've been duped by religions and religion. I don't want to have cancer. Let's see, I've never...
Ever had a partner in my life?
Yes, I'll never... yes.
Never have a partner.
Yeah, I'll never have a life partner. It's a sad one. And I'm not as spiritual as others, 100%. And the very personal aspect of this is overwhelming and devastating. But on another level, the cognitive model is saying that the facts of our life don't create our feelings. It's our thoughts about them, and that's something that's very hard for people to grasp or understand. It kind of goes in one ear and out the other. And sometimes people have said, yeah, but how about if, say, somebody's diagnosed with terminal cancer? Certainly their depression is going to be real and caused by the actual event rather than the thoughts. And so this will give us a chance to put that idea to the test, as well as to see if we can reach out to a dear friend and provide some relief, because you might not want to be spending these precious days and months embroiled in these kinds of intense negative emotions, and to be able to feel some joy, some love, some self-esteem, and some connection. And so we'll see if we can make that happen today. It sounds like that part of the meaning of the cancer that's so upsetting to you is that you're concerned from a religious point of view, that maybe there's no God, maybe there's no afterlife. You're also feeling shame, like I've wasted a lot of my life because of my alcoholism. I know that's been a struggle for you in the past. Kind of anger at religions, at self-criticism, feeling like you're not as spiritual as others or as spiritual as you quote should be. And also feeling perhaps the loss of that I'm going to be dying sooner than later, because you thought you'd live into your 80s and 90s and have a nice long life, and all of a sudden you're looking at months rather than years.
I'm just really floored by this myself, and I noticed, in addition to this morning feeling very tearful and sad, thinking of the work we'd be doing today and the significance of your diagnosis, I also felt enraged and angry that you would be taken from us prematurely, and then I felt a little embarrassed, like what's the purpose of feeling angry? Why? That's not going to change anything. And then I realized I still wanted to protest. I still wanted to feel that anger, and even if that wouldn't change the outcome, I still wanted to hold up my picket and say, this isn't fair, this isn't right. You didn't do anything wrong. You're one of the most beautiful people I've ever met, and I wish for a miracle. And this has challenged your faith. I know that a lot of times you come back to our teaching group after a little time away at a monastery, mm-hmm. and the simple pleasures there of pulling carrots, making dinner, brought you so much peace, mm-hmm. and joy. And it was like a real foundation. You have more spirituality books in your apartment than psychotherapy books. And so to be robbed of that, too, to have doubt about that, must be very disturbing to you, mm-hmm. and scary.
Yes, it is.
When you think back on some of the times we've spent together, what comes to mind?
Laughing a lot.
Yeah, that's right. Do you think we'll do that today?
Yeah, I hope so. Having good meals, having good conversation, feeling really safe with both of you, that I can really be who I am and share who I am, which is really hard for me to do, and to be able to ask for help. And I've also enjoyed, being at the intensives with you, David, and volunteering, and embarrassed at times being called to the stage to work with you, but also being honored by that.
Oh, we had some tough ones, didn't we?
Yes, we did. Very tough ones.
And then we had fun in L.A. at the Evolution workshop on
that was great.
empathy. You said it's hard for you to share who you really are. Did you say something like that just now?
I guess because I don't believe in myself, or I feel like I've have wasted my life because of my drinking, and it's hard for me to acknowledge or to accept, I guess, acknowledge and accept the gifts that people have mentioned, and I think part of it's just growing up in an environment where I was constantly being criticized and couldn't live up to the expectations, especially of my mother. So I always felt less than, and that's always been very, very strong. Which is why sometimes it has boggled my mind that I have the what I perceive to be and I believe to be true, the respect of both you, David, and you, Matt. It boggles my mind, and I'm grateful for it.
How are you feeling right now? How are we doing in terms of understanding how you're feeling today and how you've been feeling? I feel a lot of care, and I really feel that I'm being understood, and that you're getting what I'm going through, because it really is really terrifying. I mean, this is really hard, and I really appreciate the love that I'm feeling from the two of you, and I can feel it, and I can also see it in your faces.
All right, so that was the testing and empathy segment of Marilyn's live session. In our next episode, we'll be hearing the agenda setting part. And until then, we'll see you next time.
Bye-bye.
So long.
This has been another episode of the Feeling Good podcast. For more information, visit Dr. Burns' website at feelinggood.com, where you will find the show notes for this podcast under the blog page, and where you can leave your comments and questions. The website has an abundance of resources for therapists as well as non-therapists, including books, workshops, a list of online training groups around the world, and much more. Theme music is Gypsy Jazz in Paris, 1935, composed and performed by Brett Van Donsel. I am your host, Fabrice Nye, and I invite you to join us next time for another episode of the Feeling Good podcast.